Hello everybody, I welcome you all to this channel. So in this channel we will be discussing and learning together some topics from MBBS. I am a second year medical student, and I wanted to create a channel where we can learn medicine or like learn the medical subjects by understanding it. So here I am. So because today is the first basic introductory video, so I wanted to keep the topic very short and very simple. So many of you might know this topic already. So if you want a quick revision before your exams, or like so many people might be new to this topic as well, so please like do give it a try. And without any further of my preparatory speech which I apparently prepared, and it's not going as planned, without any further of that, just let's hop into the topic. So the first topic I am dealing with is from pathology, and the initial videos will be also from pathology, because as I said, I am in second year MBBS. So I would feel like the topics which I'll be able to explain, or rather I should say like discuss nicely, is like pathology, pharmacology and microbiology, which are the three main subjects of MBBS in second year. Secondly, I would like to clear this out. The language which I'll be using in my videos would be in English, because it's a professional course and also it's a professional subject. So it's better that I discuss this in English. And the secondly and the most important, I am an Indian, I know Hindi very well, but so many so many people might be there who would be watching this who don't know like Hindi. So yeah, I'll prefer speaking in English, but sometimes I might use Hindi because yeah, of course it's my mother tongue. But majority of the discussions that we will be having in this channel will be in English and always be in English. So yeah, let's just get into the topic. So the topic that I will be dealing today is a topic, like a mixture of topic from general pathology. I'm not jumping right into systemic pathology, but yeah, I have thought about it that after this video, the introductory video, I will be moving on to systemic pathology, like one of the topics that I found that yeah, I would like to clear something as well, that in this channel I'll be primarily putting those videos first, for which I didn't get any video on YouTube, and I had to sit through like hours, read Robbins, or like read so many books and come up with, like, to understand that I have to like spend so many hours reading that particular topic. So because I didn't get a video, and I am a person who learns by watching videos, or it just gets so much easier if somebody's sitting and making me understand. So primarily I'll be putting on, or like putting videos of those topics which are not there on YouTube, and like, or should I say, I didn't find it. So those are my primary targets, because there are so many other educators on YouTube who are like great of teachers. You can always go to their channel and watch their videos. But like, I'll be putting those topics which I didn't find of them, and they are also little important. So my primary targets would be that. And then if you really want me to make a video of those topics as well, please put them down in the comment section. I would be very glad to cover those topics, or like we will be very glad for a revision or for a discussion. So yeah, that's what I wanted to say. So let's just get started with the first topic which I'll be covering today. Like, it's I just as I said, that it's a mixture of topic from general pathology. Yeah, it's like a mixture of topics from general pathology. So today we will be covering all the plasias that we know, or like we have been known, which are, we have metaplasia A, then we have is a dysplasia, then we have something called as anaplasia also. Please pardon the voice, because I still don't have I definitely don't have a mic, because I've never thought but I'll do this. But yeah, I hope you can hear me at least. So we have metaplasia, we have dysplasia, we have anaplasia, and the fourth type of plasia we'll be dealing today only, which is hyperplasia. Okay. And if you don't understand my handwriting, I am so sorry. But yeah, these are the four topics that we'll be dealing today. So let's just start with metaplasia. Okay. I'll be writing it also together. So if you want notes, you can either you can just either you just can copy, or these, or like I'll say that these are the notes that I have made from Robbins primarily. So I would really suggest that after watching this, if you can just go and read through, or just see through Robbins, that would be the best. But if you can't, I'll be also writing it down. So just take a copy, take a pen, write it with me. So or if you are watching this video on 1.5x or 2x, pause it and you can write then also. So we are talking about what is metaplasia. The first thing we are discussing is metaplasia. The first thing you need to know about metaplasia is that it is a reversible change. Okay, it is a reversible change. What is metaplasia? I said it is a reversible change. How does metaplasia happens? What happens is, in this metaplasia, we have one differentiated cell type. Okay, we have one differentiated cell type. That one differentiated cell type is converting into another differentiated, or I should say another adult cell type. Okay, another differentiated cell type. This conversion is called as metaplasia. The second thing is why this is happening. Metaplasia is a adaptive response. Okay. What happens that, as I said, this is one cell type. Okay, this is one cell type. In that one cell type, there is some external stimulus, which is of course dangerous. So there is some external dangerous stimulus. Okay, so I could say this is some stress. Okay, some stress is happening here in this one cell type. So for after that one cell type, what happens? It is an adaptive response in which this one cell type is converted into another cell type. Okay, so this another cell type right here, it can withstand that stress. That's why, of course, I mean, it's common sense, right? This is why this adaptive response is happening, and this change right here is what we are calling as metaplasia. Okay, you understood the basic the basic mechanism of metaplasia. So we are discussing metaplasia first. In metaplasia, I said that is a reversible change in which one differentiated cell type is converting into another differentiated cell type, and because there was some stress and this cell type was not able to withstand that stress, so it changed into another differentiated cell type which could withstand the stress. Moving on, so we have different types of metaplasia. The most common types of metaplasia in which we see is two types. I'll be talking about the two types, which is one is squamous cell, the second is columnar, the third is connective tissue metaplasia. Okay, we have one squamous cell, we have one columnar, we have one connective tissue. Moving on to the examples of squamous cell. In the examples of squamous cell, no, remember these two, one and the second one. The first one is what we see in a respiratory tract. The second thing which we see is in cervix. What happens is, in chronic smokers, or of course those people, the respiratory epithelium, everybody knows that respiratory epithelium is made up of pseudo-stratified columnar epithelium. So in this epithelium, due to the continuous smoke, it goes into chronic irritation. Okay, it grows into chronic irritation. In that chronic irritation, what happens is this ciliated columnar epithelium is changed into, tell me one thing, if it's like this is a single layer, it is getting it is getting irritated for a long time, it will preferably change into something which is more layers. In more layers in medicine, we call it as stratified. So it changes into stratified squamous epithelium. Okay, it changes into stratified squamous epithelium. So I'll not be drawing this thing fast, but you imagine that this is some stratification happening. Okay, so this is the stratified squamous epithelium. This change is happening in respiratory tract. This pseudo stratified columnar epithelium is forming squamous epithelium, right? So this is, we call it as, this is squamous metaplasia. Common sense. Now you tell me this one thing, in cervix what will happen? So cervix is part of the female genitalia, right? So this is very prone to chronic infections. So, you know, we have cervix, maybe we have two parts, which is ectocervix and endocervix. This primarily happens in endocervix because ecto is already squamous only, okay. So, in endocervix, what happens? Again, this change happens, and the endocervix, which I said is of columnar epithelium, will change into, again, stratified squamous epithelium. So, here also we are having squamous metaplasia. Okay, here also we are having squamous metaplasia. So this is an example of squamous metaplasia. We heard two examples. One was the respiratory tract and the other one was cervix. Okay, moving on to what happens in another squamous type of metaplasia. Is another example says, you know, our secretory ducts, we have glands, we have glands. In glands we have mainly salivary glands, we have gallbladder, we have so many glands. Okay, in the glands we know the ducts are either lined by cuboidal or either lined by columnar epithelium. What happens if there is a stone? Imagine there is a stone here. This is a stone. In this stone, what happens? Continuous pressure or continuous compression is also acting as the stress, and this also changes into the stratified squamous epithelium. So this was also an example of squamous metaplasia. The fourth example which we should remember is there is vitamin A deficiency. Vitamin A deficiency. In vitamin A deficiency, what happens is it changes into squamous metaplasia again. Here what happens, I'll be discussing in thoda sa last, but abhi you remember that vitamin A deficiency will cause squamous metaplasia. So these are the four examples that are very important. You should know, and if you write these 3-4 examples, that is more than enough to fetch you nice marks also. Okay, moving on to what happens is, I told here the this thing is converting into the stratified epithelium. Tell me one thing. In example, we'll consider first of the respiratory tract only. In respiratory tract, when it was pseudo stratified, with cilia, it had so many other actions also. We know that the ciliated movement of the respiratory epithelium, just propels the dust particles, propels the microorganisms also out. So if I say that the cilia is lost, so that thing is also lost. The protective action, the mucus secretion, of course, the columnar epithelium or the pseudo-stratified, we had goblet cells also. The mucus was also produced. Now that is also lost. So this is in Robbins, it is written as it's a double-edged sword. In one way, it is helping also, but in another way, some functions are also being lost. Okay. Secondly, this is the one thing. Now we are moving to the second type of metaplasia I told you. First was squamous. Good, we are done with squamous. You know the 4 examples. Please remember it. Next, we are moving on to something as columnar metaplasia. In columnar metaplasia, what did I say? It was changing into squamous. So it was squamous metaplasia. Now it will change into, very good, columnar epithelium. So this we will call it as columnar metaplasia. So in columnar metaplasia, the primary example that I want to give you is something called as Barrett's esophagus. What happens in Barrett's esophagus is, we all know that there is acid in the stomach, right? So this is a stomach. Sorry, this is a stomach. So pardon my drawing, I'm very bad at this. And this is the lower end of the esophagus. Okay, so what happens, there is GERD. There is GERD, gastric esophageal reflux diseases. The gastric acid here is going into the esophagus. After that, what happens is, there is chronic irritation of the esophagus. In this, what happens is, and we all know esophagus is made up of non-keratinized squamous epithelium. So in this, because of chronic irritation, this stratified squamous epithelium is changed into columnar epithelium. You will say, oh, how is that even protective? What is this happening here? What happens is, this columnar epithelium is not like something era columnar epithelium. This is behaving like glandular cells. Mark my words, please. Glandular cells of intestine. This is behaving as glandular cells of intestine, and we all know intestine secretes bicarbonate ion, mucus, and this mucus is helping in protective actions against this gastric acid. This is the pathogenesis, and this is why there is this changing happening. And because in this change we are going from stratified squamous epithelium to columnar epithelium, we will be calling it as columnar metaplasia. Okay, I hope you understood this. Secondly, we are going to this is one of the primary examples. Oh, I didn't write the name, I'll write it. Okay, this is the Barrett's esophagus. Okay, please. Next is, we will be going on to something called as connective tissue metaplasia. In connective tissue metaplasia, what's happening is, there is connective tissue formation in, like, there is some connective tissue formation, that we know, because when stratified squamous was forming, we called it squamous. Columnar was forming, we called it columnar. But obviously we don't need some Chanakya buddhi, we know, but obviously there is some connective tissue formation happening. What happens is, the primary example in this, also you have only one example. I really want you to know only one example. There might be so many other examples, but the thing that you need to know for your exams and what is written in Robbins is, one is myositis ossificans. Myositis, muscle. Ossificans, ossification. Common sense. Now I really want you to apply your common sense in here, and then if I am saying this, you should be able to think the same way. We have a muscle. In this, there is some ossification happening. So that is called as myositis ossification. So I know you get it. You are much more intelligent than I am. I am not even intelligent. Okay. So what happens is, there is some intramuscular hemorrhage happening. There is some intramuscular hemorrhage happening. Blood is coming out. Wait a second. We'll make blood. Okay. There's some blood coming out. Because of this blood, there is some hemorrhage happening, and because of this cell tissue injury, this blood is coming out. Of course, there might be some injury. So because of this injury, hemorrhage is happening, cell or tissue injury is happening. So there is some bone ossification. There is some bone ossification, bone formation, because this bone formation will be able to withstand this injury in a better way. So this is called as myositis ossificans. This you can either write it, don't draw this image also. If you have 2 seconds in your exams, draw this image also. It will be way better. I mean, I always make, my professors also tell me every time to just make diagrams as much as possible. So we'll just make this diagram. It will only take 2 seconds. Moving on to the main part of what happens in metaplasia, what is happening, what is the mechanism. Please listen very carefully. If you are writing, I really want you to stop for 1 minute and concentrate here in what I am saying in the mechanisms. Just concentrate for 1 or 2 minutes, please. Okay, we'll see the mechanisms. It's very important to know, because so many people are very confused about this mechanism. I don't know why, because but we have some mechanisms. So we'll just listen to me for once. Take a deep breath, put your pens down, just listen to me, just look here. After that, I'll just scroll back. You can just take a screenshot of this notes also if you want. So सबसे पहले तो just be clear about this thing. If you are thinking about this mechanism, so just drop it, because it's absolutely wrong. So if you are thinking that this was a normal epithelium, okay, मान लो this is a squamous. Out of nowhere, it अचानक से, by चमत्कार or something, it changed into columnar. There is no chamatkar happening, please. Can you tell me, is it not humanly, is it by common sense or something possible that this thing will, these all layers will vanish and only the columnar is here? Is it possible? It is not possible. By common sense, by anything, it is not possible. So this though we know that there is no change in phenotype. Mark my words. There is no change in phenotype. This is C. No change in phenotype of an already differentiated layer. Already differentiated layer. There is no change in phenotype in an already differentiated layer, for God's sake. Okay, I'll tell you what really happens. This is absolutely wrong. Where is my pen? Okay, this is absolutely wrong. This is not happening. What is happening now? I'll tell you. What exactly is happening is, there is what can happen. You just think, just pause the video, think for 1 minute or whatever time you need, just 1 second also you can think what might be happening. What are the cells in the body which are actually responsible for creating new cells or creating the whole body? These are stem cells. These are the stem cells. So what might be happening? Chalo, Bhagwan ji told this in one particular place, the stem cells are there. Okay, Bhagwan ji told you are supposed to make one type of epithelium here. I mean, just imagine, I'm trying to make it simpler for you. What happened is, there was some reprogramming. In these stem cells which created a new epithelium. Is it making sense? Absolutely making sense, because this is what is happening. So Robbins says there is some reprogramming of stem cells, or you can say the precursor cells, which will make them differentiate along a new pathway. Okay, which will make them differentiate along a new pathway. The real question is why? Bhagwan ji, I just chumma said, but why? The thing is, when we were having an injury, okay, what was happening? We all know everywhere in pathology, everywhere, and I swear by everywhere, I mean everywhere, whatever is happening, there's some cytokines, some interleukins, some chemokines, some growth factors doing that job. Okay, and we all know when the injury strikes, these are the first people, these are actually the Twitter. Their work is to spread this news to everybody that injury happened. So what happens is, because of injury, this thing is happening, and these Twitter people, what they do, they generate signals as usual. They generate the signals. The signals are generated because of cytokines, growth factors, and there are some extracellular matrix components also. But the signals are generated. When signals are generated, what happens? Everywhere, every time, this is the same thing will happen everywhere. There's some gene expression happening. Gene expression will then drive the cell towards a specific differentiation pathway. Okay, this is alternated. Matlab, the naya cheez has happened, the alternative has happened. Okay, this is it. This is the mechanism of metaplasia. This is not happening. Of course, nothing in chamatkari here. This is the scientific way of what is happening. And if you want, you can just take a screenshot now. I hope you listened. Okay, now moving on to the examples that I said. Now I'm not a mystery man or something. I'll tell you this vitamin A. Okay. What happens in vitamin A deficiency or excess? In vitamin A deficiency or excess, what happens is, vitamin C is also called as retinoic acid, retinol, whatever that is, retinoic acid. What happens? We know that retinoic acid forms the major components of receptors. Okay, both membrane receptors and nuclear receptors as well. So what happens is this retinoic acid, this is RA is retinoic acid. Retinoic acid, this regulates gene transcription nuclear receptors. Okay, these regulates the gene transcription nuclear receptors, and then these retinoic acid, if it is a deficiency also, excess also, it influence differentiation. It influences differentiation of progenitors. We have progenitors, right, from the our mother cells, which are the stem cells. Okay, this is what happening in retinoic acid. So these regulate the gene transcription nuclear receptors. Of course, if they are regulating gene transcription nuclear receptors, they are indirectly, they are saying they regulate the gene expression. Okay, they regulate the gene expressions and then influence differentiation of progenitors from stem cells, and this is how they control metaplasia. Here I am done with metaplasia, and let's move on to our second topic, which is differentiation and anaplasia. What is differentiation and anaplasia? If we talk about differentiation and anaplasia, we have, let's just write this topic. Why do we, it's always like that we always study these topics together. If in anywhere, if you see in any kind of book, be it Robbins, be it Harshmohan, be it Ramdas, be it Kataya, in any book, it's always written together. It's always differentiation and anaplasia. Why is it not anaplasia alone? That is because that lies, like the answer lies in the definition of anaplasia. Before understanding the definition of anaplasia, you need to understand what differentiation actually means. So if I talk about differentiation, so differentiation is, before that I'll tell you something. So मान लो this is a normal thingy. Okay, consider this is a normal thingy. I mean in here metaplasia happened. Metaplasia happened. Metaplasia is cancer happened. Neoplasia, metaplasia, not metaplasia, sorry, not metaplasia. See, this is what common people do, and I said I am common people only. This is what cancer or neoplasia, cancer also named. Bro, I am studying in MBBS, I should be behaving like one. Okay, neoplasia happened. Pardon me guys, as I said, we are discussing here, so I am also allowed to make some mistakes, and you are also allowed to correct me. If you feel like I have gone wrong somewhere, please drop in the comments so that I don't make mistakes in the future and I become nice of a doctor. Moving on. We are having neoplasia here. Neoplasia means we are having some hyperchromatism and all that thingy that's happening, no? Basic thingy that is going on. Okay, we have metaplasia happened here. Metaplasia, neoplasia happened here. Okay, what exactly is differentiation? So differentiation actually means the extent. Remember, please write it with me, otherwise you will not understand this. Extent to which neoplastic parenchyma cell, extent to which neoplastic parenchymal cells resemble the corresponding normal parenchymal cells. So we have extent to which neoplastic parenchymal cells resemble the corresponding normal parenchymal cells. So मैं एक बार हिंदी में बोल देती हूँ ताकि मुझे थोड़ी तसल्ली मिल जाए. सो अब देखो, ये नॉर्मल सेल्स जो क्या मतलब जो न्यूप्लाज्म से पहले जो नॉर्मल था ना, सो न्यूप्लेसिया के बाद जो है ना, तो ये कितना इससे मिलता जुलता है, ये है हमारा डिफरेंशिएशन. इफ आई से इट इन इंग्लिश, दैट इज़ कि आफ्टर द न्यूप्लेसिया हाउ मच रिजेम्बलेंस इट हैज़ विद द नॉर्मल प्रीवियस वन. That is what we call differentiation. So if it is resembling way too much, I mean the epithelial type is same, only some here and there correlative difference is there, then we say this is well differentiated. If if it is not resembling at all, कुछ भी same नहीं है, nothing is same, so we will say it is poorly differentiated. Genius. Next, what we have is this. The next thing, our mystery man, our hero. Our hero is anaplasia. What is anaplasia? Anaplasia is actually lack of differentiation. Lack of differentiation is anaplasia. Understood? So differentiation is this. Differentiation is this. Read it on your own. And anaplasia is this, lack of differentiation. Moving on. We know there are two types of tumors. Okay, there are two types of tumors. First is benign tumor. Second one is malignant tumor. First one is benign, second one is malignant. Benign tumors are generally, I'm saying generally, well differentiated. So the resemblance is बहुत ही ज़्यादा. It's like twins. Okay, not twins, but yeah, you get the difference. Malignant is, on the other hand, malignant, people, common sense, nice people. Okay, nice people will say it is poorly differentiated. No, you are living in way too delulu. Next, I'll tell you. This has a wide range of differentiation. Okay, this has wide range of differentiation. And what do I mean by wide range of differentiation? By a wide range of differentiation, we say we have some malignant neoplasms which are like very well differentiated. Then we have some neoplasms which has no evidence, which are like very poorly differentiated. Then we have, you only tell me what will be there. Moderate. We have moderate level of differentiation on it. We have well, moderate, poorly. Wow. Next, I said you that, like, you know, but yeah. Okay, these are the three different types of malignancy. But you know something. There's something called as anaplasia that I just told you. Anaplasia is called something else also. You know what? Like, you know, there are some things that we give hashtags to. So anaplasia is hashtag hallmark of malignancy. What does this mean? I just told that some malignants are well differentiated. What does this line mean? It took me a year of second year to understand this line, but yeah, I have now understood, so I think I can say this. It means if there is anaplasia, there is malignancy 110%. Okay, like there has to be malignancy because there is anaplasia. Okay, so many times it is there has to be if there is anaplasia, like it is very poorly differentiated. His stem cells like properties are seen in those neoplastic cells. It is malignant. Okay, it is most probably malignant only and malignant only. Do I make sense? Yes, I do make sense. So this is known as the hallmark of malignancy. Or what can you understand? This simple line, if you don't understand my confusing statements, the statement which I can say very not confusingly is, you can understand if a cells are becoming anaplastic, no? If the cells are becoming anaplastic, no, they are entering malignancy. They will 110% turn malignant. They might not be malignant at this moment, but they will 110% turn malignant. This is what is known by hallmark of malignancy. Hallmark means like a milestone, like, you know, the you know, this, what do you say, this stoppage or stop that has came, and from there malignancy is only starting. So this is what is meant by hallmark of malignancy, which is anaplasia. Moving on. Okay, moving on to the important parts which you will need to write in your exam. So I really want you to take a copy pen. Yes, in the same, take a copy pen and write whatever I'm writing. What are the morphological and functional changes observed? I just said that everything is not, you know, well differentiated. Everything has changed. What are the changes that I was talking about, which will tell if it's differentiated or not? The first thing which we'll see is something called as, अच्छा देखो, the normal cells कितना अच्छा, you know, it's so nicely arranged. this is not arranged, but imagine this is so nicely arranged, like a bunch of laddus. Okay, like a bunch of laddus it is arranged. But in anaplasia, what happens? There is pleomorphism. It's like somebody was blindfolded and then tried to make the laddus. It's like that. There is difference in sizes. Okay, there is different in size. There is different in shapes. There's some cells like this kunni, I mean this small, and then there are some this big of a giant cells also. This is what is pleomorphism. There is difference in size and shape. That's pleomorphism. The second thing is there are some abnormal nuclear properties. Hold right, abnormal. I don't need write. It's okay. I wrote. There are some abnormal nuclear properties. In this, what does it mean by abnormal? What can abnormal be? I mean, it forgot something, it happened something happened. I'll tell you. There are some qualities which will happen. Normal cell, मान लो, I'm drawing here normal cuboidal cells. It has something called as basal polarity. What is basal polarity? That all the nucleus will be lying in the base only. This is what it is called as basal polarity. What happens in malignant cells is there is no basal polarity. Can you see any basal polarity? This is what malignant. It's not because I am drawing this way, because it happens this way. I can show you photos also. Oh yeah, after that we'll discuss photos. But there is loss of basal polarity. That is the first point. In the second point, which is nuclear properties, which is abnormal nuclear properties. Second point is, can you see I made a large nuclei? Do you think I was stupid enough to make this? No. This is the large nuclei. Okay. There's a large nuclei. In scientific terms, we call it that increased nucleus to cytoplasm ratio. And if you are very intelligent, I'll tell you that nucleus to ratio increased means there is increase in the size of the nucleus. Third, we have something called as unisonucleosis. What do you mean by unisonucleosis? Do you think I made it this way because I was lazy? No, I was not lazy. Because there is unisonucleosis, means the nucleus also is of unequal size and shape. Okay. Moving on to, there's something called as hyperchromatism. To this point only, okay, to this point only, there's something called as, we have prominent nucleoli. And these 2 points are because there is increase in nucleoprotein. There's increase in nucleoprotein which causes hyperchromatism and prominent nuclei. What we do is, we are pathologists. I mean, we are not pathologists, but yeah, pathologists, they stain this nucleus or nuclei thingy with silver. There is something called as, you might know this, you might not know this, but there is something called as nucleolar organizer region. There's something called as nucleolar organizer region, NOR. When we say it with AG, it becomes Agnor. You know, this reminds me of Ragnarok, but yeah, this becomes Agnor, and the Agnor is stained very nicely, एकदम बहुत ही अच्छा stain that takes, and then this, because there is increase in nucleoprotein, that's why this is very well stained, and it can be visible also. Okay. Next, moving on to the third point. Nuclear mein these all changes happen. So there is nuclear properties may change, which is nuclear morphism is happening. And unisonucleosis is happening. Loss of basal polarity is happening. There is large nuclei also. There's NC ratio increase also. There's hyperchromatism also. There is Agnor is very well stained also. Moving on to the third point, we can see abnormal mitosis. What does this mean? Ab you will say, mitosis is there in our body. Our epithelium is always into dividing stage. Our bone marrow cells are always into dividing stage. Okay, these are some dividing cells in our body. Is that what you mean by abnormal mitosis? No. These are the normal cells which go into, division. This is not normal, but yeah, these are the normal cells. What do you mean by abnormal mitosis? Okay, and sometimes there is something called as hyperplasia, which I'll be taking like after this only. This is something called as this is the normal only, but in neoplasia, what happens? There is not only abnormal mitosis, there is atypical bizarre mitotic figures. Atypical bizarre mitotic figures. What is this? In this, normally what happens? Consider these are the spindle bodies. In a cell, there is normally two spindles at the time and they divide the cells like this. In this, we have abnormally bizarre mitotic figures, means there are like one spindle is here, 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 one spindle is here. There is abnormally mitotic division from all the directions, which is we are calling atypical bizarre mitotic figures. There is tripolar, quadripolar, multipolar spindles there. Fourth one is we have something called as functional changes. What does functional changes means? Do I need to write here? We have tripolar, multipolar, spindle. Next, we have something called as functional changes. It can be in the form of qualitative also. It can be in the form of quantitative also. Okay, there can be absent of product also. That comes in quantitative, but yeah. There can be secretion of some abnormal product also, which is not normal for there. It's not like it's abnormal. It's abnormal product according to that cell. Then there can be secretion. Yeah, maybe. So in qualitative, it can increase, decrease. Qualitative may we have abnormal product. Quantitative may it can increase or decrease. So qualitative may what happens is there's some abnormal product secretion happening. What do you mean by abnormal product? So many times they can secrete fetal proteins. Oh no, spelling of fetal proteins. Okay, they can secrete this. In multiple myeloma, there's increase in M proteins. Sorry, M band, not M proteins. There's secretion of light chains, increased secretion of light chains, which is seen as M bands. All that. Then what happens? There's something called as paraneoplastic syndrome. What do you mean by paraneoplastic syndrome? This is important. I want you to know that. Okay. What do you mean by paraneoplastic syndrome? What happens in paraneoplastic syndrome is there's this much of a great anaplasia that this one adult cell type has changed into something other, and then something other is doing hormone production. So we'll call it, out of nowhere it came, right? So this is ectopic hormone production. This is ectopic hormone production happening, and besides the endocrine system, hormones are produced by the certain tumors. Ectopic hormone production by the tumors. Okay. Which is of course unrelated to endocrine system. This is called as paraneoplastic syndrome. So if there is hormone production, so there will be increase in hormone levels of those, and that will causes, for example, it can cause Cushing syndrome, all those hyper hormone syndromes, all that thingy will cause. This is called as paraneoplastic syndrome. Okay, moving on to is something called as, the examples of these thing is bronchogenic carcinoma. The bronchogenic carcinoma, they produce corticotropin, they produce PTH like hormone, parathyroid like hormone, they produce hormones like insulin and glucagon. So these will create the access things of these hormones. So this is what anaplasia and differentiation is. Now only two subsets left, which is dysplasia and hyperplasia. I'll be ending this video and I'll be taking you to the part 2, because I think this video is already I don't think if it's recording now. Did you hear what I just said? I think I'll take a part 2 for this, and that will be almost 10 minutes or something. So because we only have dysplasia, which is like very correct, and then we have something called hyperplasia, that is also very simple. So, and also these two are, dysplasia is thoda sa mushkil, but hyperplasia is easy only. I think you might have understood hyperplasia. So this is it. Up next is, after this I'm thinking of taking RCC, which is renal cell carcinoma, which is a very important thing also, and I didn't find any video of that also. So we'll be taking that. Till then, I'll come and talk to you in the next part. But abhi ke liye, if you like this video, if you learned something also new, even one word, if you learned something new, then please do like this video, watch this video, enjoy, and if you do like talking to me, consider subscribing. I don't know if you hear that also. I don't know what's happening to me in between. Okay, if you wanna talk to me again, so I'll be back with another video on another day. So tab tak ke liye, take care, bye bye, Radhe Radhe.